Um, Good day, everyone. My name is Onowori Victor. I am a neurology aspirant and currently doing the Chin Change Comprehensive Review. We've done questions 1 to 14 in our previous episodes, and this is going to be a session that deals with questions 15 to 17. If you have any comment, any contributions, please don't forget to put your comments on the chat box. You could also like and subscribe. And that being said, let's begin. So we have a very interesting question or set of questions. Um, it says a 9-year-old girl presented to your office with complaints of diplopia. This began after she had a bad fall off her bicycle, hitting her head. On the basis of the directions of gaze noted on examination and shown in figure 1.1, what nerve is involved? Now, this is actually a very interesting case in the sense that it's testing your knowledge of the extraocular muscles and something we call field of action of each extraocular muscle. So before we dive into this, the options, let us take a pretty good review of the field of actions of extraocular muscles. So before we start this, I need to give credit to Cornel Tolanis, and I will put a link on to the YouTube channel. This YouTube channel actually helped a lot. It helped me to understand the concept of field of action. So, as mentioned there, the field of action is the position in which we can actually assess the primary action of the extraocular muscle. Now, if you take a look at this, you can see about 9 pictures in here. We have the eye in its primary position, and usually what I use to recall this is by dividing this chart into what I call the cardinal point, 9 cardinal points. So I basically say we have the north, we have the south, we have the east, we have the west, we have the northeast, we have the northwest, we have the southeast, we have the southwest. And why is this very important? This is important because the the north, south, east, and west are called the secondary position of the eye, while the northeast, northwest, the southeast, and the southwest are called the tertiary position of the eye. Generally, if you want to know which of the scapular muscle has a lesion or which of the scapular muscle is damaged, it's best to check using the tertiary position of the eye. Now, that being said, let's take a look at this chart. So, a very simple way to remember is by knowing that in the abducted position, that's the abduction, when the eye is abducted, generally it's kind of triggers the field of action for two muscles. The first is the superior rectus, and the second is the inferior rectus muscle, right? So now, if the eye is abducted and elevated, that triggers the superior rectus muscle. So you can actually see the full action of the superior rectus muscle when the eye is abducted and elevated. If the eye is abducted and depressed, you can see the full action of the inferior rectus muscle. For the adduction, for the adduction aspect, if the eye is abducted and elevated, then you can see the full action of the inferior oblique muscle. And if the eye is adducted and depressed, you can see the action of the superior oblique muscle. So going back to this diagram, you can see that this is the action. So this eye is actually abducted and elevated. So this particular eye is telling us, oh, this is the action of the superior rectus muscle, the right superior rectus muscle. This is moving to the right. So basically, this is actually being pulled by the right lateral rectus muscle. This is um, abducted and going downwards. So this is the action um, of the inferior rectus muscle. Yeah. And looking at this is adducted is abducted and elevated. So this is the action of the inferior oblique muscle. This is adducted. This is the action of the medial rectus muscle. This is adducted and depressed. This is the action of the superior oblique muscle. Now coming to this is adducted and elevated. So this is the action of the inferior oblique muscle. This is adducted. This is the action of the medial rectus muscle. This is abducted and depressed. So this is the action of the superior oblique muscle. This is abducted away, abducted and depressed. This is the action of the inferior rectus. Um, this is moved to the left is abducted. This is the action of the lateral rectus. This is abducted and elevated. So this is the action of the inferior oblique muscle. Now, generally, we don't use this. Neither do we use this. Using anything that they will not really give you a, they won't really tell you which of the muscle is affected. They will not really isolate the muscle. And why? The reason is because this depression can be caused by both the superior oblique and at the same time the inferior rectus. So it won't really give you a good idea of which extraocular muscle is affected. So that being said, let us go back to our question. Now, taking a look at this, we can see the eye here is this particular, at least with this is abducted, abducted away, and elevated. Do we have an issue with that? I don't think so. So that means the superior rectus here is working. This is abducted to the right. So this means that the lateral rectus is working. This is abducted and depressed. Yeah. So this means that the inferior rectus is working. Okay. Now this is in the abducted state. In the abducted state, this is still the right eye. In the abducted state, this is elevated. So this means the inferior oblique is working. This is in the adducted state only, moving to the left, the right eye moving to the left. I mean the medial rectus is working. This is abducted and look at the eye is going down, it's depressed. This means that the superior or the superior oblique is working. Now let's look at the left eye. Now this is adducted and elevated. Yeah, we can see the elevation abducted and elevated. So that means that our um, inferior oblique is working. This is adducted. This means that our medial rectus is working. Now this is adducted, but it is not depressed. Take a look at this. If you look at this other eye, you can see that this one was depressed. But look at this. This is just almost as if the child is just looking to the right. Yeah, so you can just at least asterisk this. Yeah, so we think, okay, is it that the superior oblique is not working? Yeah, so let's take a look at this place. So here we have the eye. It's going up, it's abducted and elevated, so that means the superior rectus is working. So for here, that means that the lateral rectus is working. So that this is going down, so this means that the inferior rectus is working. So that means that the issue is most likely here, and then so the superior oblique. Now remember LR6 S24 or that's the superior oblique by the fourth nerve, which is the trochlear nerve. So this is the left eye. Now the left trochlear nerve. That's option D. The left trochlear nerve. Now please don't be deceived by these two pictures. These pictures going up or going down will not that looking upwards or looking downwards will not give you a realistic picture because these actually test two different um extraocular muscle. So don't ever use this when you're trying to assess for extraocular muscle damage or lesion. Right. So now that we've talked about the trochlear nerve and we've talked about the extraocular muscle affected, the superior oblique, let us take a deep look into the trochlear nerve. Now, the trochlear nerve is actually a very unique nerve in the sense that it's the only cranial nerve that exits dorsally from the midbrain, which is a part of the brainstem. Now, the motor nuclei of the trochlear nerve is at the level of the inferior colliculi, and when they come out of that nuclei, they actually decussate before they exit the midbrain at the level of the inferior colliculi. Now, this means that the motor neurons that are located in each um, trochlear nucleus actually innervate the contralateral superior oblique muscle. Now, after exiting the inferior colliculi, what happens is that they curve ventrally right around the cerebral peduncle and the pass between the posterior cerebral artery and the superior cerebellar arteries. They just stay lateral to the oculomotor nerve. Now, it's of note that the trochlear nerve is actually the smallest nerve, and even though it's the smallest nerve, it actually has the longest intracranial course, and that makes it very prone to injury. So, like we said before, it innervates the superior oblique muscle, and its main function is to cause the depression and intorsion of the eye, especially in an adducted position and adducted position. Patients who have issues with their trochlear nerve, that's when they have trochlear nerve palsy, may present with vertical diplopia. So, usually, the regular diplopia we are aware of is a horizontal diplopia where people see objects side by side. But in this particular type of diplopia, they see objects up and down. And sometimes they may actually have another very interesting presentation, which we call torsional diplopia, where objects are tilted. Now, because of the loss of intention and depression from the affected eye, that eye is usually extorted and elevated due to the action of its antagonist, the inferior oblique muscle. So that means that objects that are viewed in the primary position of gaze, as a downward position, will actually appear double, and especially when the patients are going down a flight of stairs. Now, in order to improve their symptoms, patients usually compensate by tilting their head to the lateral side of the lesion. And basically, what this does is that it allows the unaffected eye to undergo intorsion in order to compensate for the left eye that is extorted, and this causes the diplopia to improve. Now, generally, when they tilt their head to the contralateral side, they also slightly flex their neck down. That's the their chins are downwards, and this actually helps a lot to compensate. So question 16. In this type of nerve lesion, which of the following corrective head positions would be expected to lessen the severity of the diplopia? So we already know that the issue is with the left trochlear nerve. And if the problem is the left trochlear nerve, that means that this patient will need to tilt their head in the contralateral direction as it's not affected. That means they will tilt their head to the right. So the head will be tilted to the right, and the chin will be bent inward. So let's see the options. Head tilted to the left, that's false. Head tilted forward, that's false. Head rotated to the left, that's false. Head tilted to the right, that is true. Now remember, tilted, not rotated. E. Head rotated to the right, that is false. So question 17. Which of the following is true regarding the cause and innervation of this nerve? We're talking about the trochlear nerve. The motor neurons that innervate the motor neurons that this nerve originates from innervates the ipsilateral superior oblique muscle. So that's false. We said the motor neurons innervates the contralateral um, superior oblique muscle. B. The motor neurons that this nerve originates from innervates the contralateral inferior oblique muscle. That's false. It's the superior oblique muscle. Option C. This nerve passes between the posterior cerebral and the superior cerebellar arteries. That is true. D. This nerve has the shortest intracranial course, that is false. It has the longest intracranial course. And E, the axons from this nerve decussate prior to exiting exiting ventrally at the level of the midbrain. That's false. It exits dorsally at the level of the midbrain.